My name's Jenna. Myself, Maddie and Kate are third year CQU sonography students here today to give you a presentation on portal vein thrombosis. We will be covering the signs and symptoms, treatment, sonographic appearance and imaging protocols in relation to this. What is portal vein thrombosis? The portal vein, as we know, is a very important vessel in the hepatobiliary system for delivering nutrient-rich blood to the liver for its metabolic and detoxing functions. Portal vein thrombosis occurs when there is an occlusion within this vessel. Due to the blockage, portal hypertension can then occur, which can lead to other problems such as splenomegaly, esophageal and gastric varices, and fluid accumulation within the abdomen. The portal vein enters the liver at the porta hepatis, and once it has entered the organ, it is then termed intrahepatic. The large majority of all portal vein thrombosis cases are intrahepatic, with only 5 to 10% of all cases being termed extrahepatic thrombosis. Symptoms and causes. There are many factors which can lead to the production of portal vein thrombosis. Around 25% of all adults with liver cirrhosis have portal vein thrombosis. This is due to the liver being scarred and impeding the fast flow of blood through the organ, which leads to a clot far more easier. Often several things can work together to cause portal vein thrombosis. Some other leading causes that can be found in portal vein thrombosis, apart from cirrhosis of the liver, can be inherited or acquired disorders of the coagulation pathway, which makes it easier for a blood clot to form. Also sepsis, irritable bowel syndrome, estrogen use, and also neoplasms such as liver, pancreatic and kidney cancers are all factors which can cause portal vein thrombosis. In most cases, it's completely asymptomatic. However, in some people, problems can arise due to the ongoing portal hypertension that occurs with the thrombosis. Varicose veins can occur within the abdomen and they can rupture and bleed and cause further issues such as vomiting blood and black stools. So we have some statistical data on the presence of portal vein thrombosis within the population. As we can see, within children, 50% of all cases of portal vein thrombosis are due to an intra-abdominal infection such as appendicitis, and the other 20% of all cases in children are due to a congenital anomaly of the biliary tract. Within adults, the large majority are due to cirrhosis of the liver, so that's up to 34% of all adult cases. 21 to 24% are due to neoplasms, usually occurring within the pancreas, liver or the kidney. And we have 10 to 12% of adult cases are due to acquired disorders of the coagulation pathway. So a disruption to the coagulation pathway is obviously going to have a pretty big effect on the production of thrombus within the body because the body's usual system for dealing with that is disrupted. And we have 8 to 15% of cases are idiopathic, which means there's no underlying cause that has been found for the portal vein thrombosis. And overall in the population, there has been no differences in the two sexes reported. However, there is a slight prevalence of males with cirrhosis, which then leads on to portal vein thrombosis. Complications. Collateral pathways can form when a vein is blocked within the body. This means that new veins form new pathways to get the blood around the occlusion. This often occurs between two branches of the portal vein within the liver when the main portal vein is housing the portal vein thrombosis. This can lead to a disruption of the usual flow of blood through the organ and also have effect on portal vein hypertension. Ascites can form within the abdomen, which can lead to pain, swelling and bloating. You can also get extension of the thrombus through to the mesenteric arcades. If the thrombus gets down into the mesenteric artery or any other mesenteric vessels that feed the gastrointestinal tract, this can lead to ischemia and infarction of the bowel. So this means that the bowel will not receive enough blood due to the occlusion and that portion will become necrotic and die. You can also get varices and variceal hemorrhage can occur, and as I said previously, that can cause vomiting blood and black stools because that will arise from the gastrointestinal tract also. And in extreme cases, hepatic encephalopathy can occur. So this is the occurrence of a confusion and an altered level of consciousness. It can also get to the state of being in a coma as a result of liver failure. So this is really life-threatening, but this complication is relatively rare. The prognosis for portal vein thrombosis is generally good. The overall mortality rate is less than 10% and 75% of all patients with portal vein thrombosis are alive after 10 years. So generally speaking, a patient diagnosed with portal vein thrombosis, the prognosis is relatively good. However, it does worsen with the presence of other factors like liver disease, mainly cirrhosis, and liver cancers, and other malignancies within the pancreas and kidneys. So now Kate and Maddie are going to speak about the treatments, sonographic imaging, and the sonographic appearance.
The rational management of PVT is still not adequately understood, as there is a lack of randomized controlled trials. This makes treatment individualized. However, the overall aim of treatment is to recanalize the portal vein by reversing or preventing advancement of thrombosis in the portal venous system, as well as treating complications of an established PVT. As acute and chronic PVT are two distinct disease entities, they require a somewhat different treatment approach. The management of patients with acute PVT is based on prevention of further thrombosis and therapy aimed at recanalization, treatment of complications such as bowel infarction and concurrent disease, and identification and, if possible, treatment of underlying thrombophilic risk factors. Anticoagulation is the mainstay of treatment. If PVT is detected early, it should be treated for a duration of 3 months when there are no contraindications present. Early administration of anticoagulants such as heparin is essential as recanalization rates decrease when anticoagulation is delayed. Apart from anticoagulation, several other treatment modalities have also been employed to achieve recanalization of the obstructed portal vein, such as the use of local thrombolysis in the early phase of PVT. Furthermore, if apart from the portal vein, the splenic and mesenteric veins are also obstructed, there is a substantial risk of intestinal ischemia and subsequent bowel infarction. This is the most severe complication of acute portal vein thrombosis and often requires immediate surgical intervention to resect necrotic parts of the bowel. If left untreated, bowel ischemia can lead to major complications such as intestinal perforation, shock, multi-organ failure, and even death. The management of patients with chronic PVT is based on treatment and prevention of variceal bleeding. Therapy for chronic PVT is guided by the presence and severity of complications related to portal hypertension. For patients with chronic PVT, bleeding from gastroesophageal and duodenal varices is the most important complication of PVT-induced portal hypertension. Primary prevention of bleeding is recommended in patients with large, greater than 5 mm varices. Treatment with non-selective beta blockers and endoscopic band ligation are equally effective and both significantly reduce the risk of first bleeding episodes. When these therapeutic options fail, and in patients with current variceal bleeding, a shunting procedure could be considered. Recent interest has gone out to the use of transjugular intrahepatic portosystemic shunts. Several studies have reported the successful use of TIPS in the management of patients with PVT. Nevertheless, a TIPS procedure can only be performed in selected patients. The procedure is technically not feasible due to extensive thrombosis involving the splenic and mesenteric veins. When using non-invasive imaging techniques, the diagnosis of PVT can easily be established. Computerized tomography, CT, magnetic resonance imaging, MRI, and Doppler ultrasound can all be applied to demonstrate either the absence of flow or the presence and extent of a thrombus in the portal vein. CT and MRI provide additional information such as extensions of thrombus, evidence of bowel infarction, and status of adjacent organs. On non-contrast enhanced CT, portal vein thrombus is generally seen to be isodense to adjacent soft tissue. Ultrasound is the investigation of choice and should be the first imaging method used in patients with a suspected abdominal disorder because it is non-invasive and well tolerated by the patient. PVT is more frequently being diagnosed by a wide use of ultrasound Doppler equipment. Doppler ultrasound is highly accurate at detecting thrombosis involving the trunk of the portal vein and intrahepatic branches, as it has a sensitivity of 89% and specificity of 92%. Furthermore, it provides additional information concerning portal flow and its direction. Endoscopic ultrasound has also been reported to be a sensitive and specific test to diagnose portal vein thrombosis. It is important to have endoscopy in patients with PVT, as portal hypertensive gastropathy is more often present in the acute PVT with cancer or cirrhosis, while large esophageal varices are present more often in patients with chronic PVT.
Portal vein thrombosis must be considered when no Doppler signal is detected within the portal vein. A thrombus may form due to a blood clot or a tumour invasion. The sonographic findings of portal vein thrombosis are hypoechoic intraluminal echoes within the portal vein, an increase in portal vein diameter, prominence of the intrahepatic arteries, and absence or altered portal venous flow. Acute thrombosis of the portal vein is usually associated with an increase in portal vein caliber, to greater than 13 to 15 millimeters, and the absence of variation in portal vein diameter during respiration. Acute thrombosis of the intrahepatic portal vein branches may be difficult to detect with ultrasound imaging alone, as the thrombus may be of similar echogenicity to the adjacent liver. With time, it becomes more echogenic and therefore easier to identify. Colour Doppler should demonstrate absent flow in the portal vein and will make it easier to detect partial thrombosis. It is important to have the Doppler gain and filters set correctly in order to visualize the thrombus and avoid color overwrite. Patients with long-standing portal vein thrombosis may develop collateral flow into the liver via a lace-like network of veins. This is known as cavernous transformation of the portal vein, or cavernoma. The absence of a clearly defined portal vein is a notable finding of cavernoma on grayscale imaging. Colour Doppler reveals a web of numerous serpiginous small veins, typically around the liver hilum. Spectral Doppler shows a portal flow in the branches of the cavernoma. Colour Doppler is also useful to help evaluate for a tumour thrombus, which will show internal colour vascularity. Bland thrombus, in comparison, is bland on Colour Doppler. At grayscale ultrasound, both benign and malignant forms typically manifest as an echogenic intraluminal filling defect. The most reliable distinguishing grayscale ultrasound feature of malignant thrombus is the combination of an echogenic filling defect with an adjacent liver mass. In occlusive thrombosis, colour Doppler ultrasound will demonstrate absent flow. There will be no normal portal venous waveform in the spectral Doppler trace. In some cases of malignant thrombosis, there may be colour signals within the thrombus. This finding has been referred to as the thread and streak sign. When sampled for spectral evaluation, these colour signals show arterial waveforms, which is a specific sign for tumour thrombus. Portal vein flow should always be antegrade, which therefore creates a waveform that is above the baseline. Hepatic venous pulsatility is partially transmitted to the portal veins through the hepatic sinusoids, which accounts for the cardiac variability seen in this waveform. It should also be kept in mind that the flow velocity in this vessel is relatively low compared with that in the vessel coursing next to it, the hepatic artery. Although normal phasicity ranges widely through the portal veins, the PI should be greater than 0.5. Abnormal portal flow can be seen as increased pulsatility, slow venous flow, hepatofugal flow, or absent portal venous flow. In this image you can see a blue colour Doppler image of the left portal vein. You can see a tubular echogenic plug of thrombus within the left portal vein. You can see that its echogenicity is very similar to that of the adjacent liver parenchyma. For a liver scan, the patient is required to be NPO for 6 to 8 hours before the examination for adults, 6 hours for children, and 4 hours for infants. However, emergency examinations may be performed without preparation. We must use the highest frequency abdominal transducer possible to obtain optimal resolution for penetration depth. There must be sufficient imaging depth to visualize the structures immediately posterior to the region of interest. The gain settings must be set appropriately to display the normal liver parenchyma as a medium shade of grey, with adjustments to reduce echoes within the vessels. Harmonic imaging or decreasing system compression can be used to reduce artifactual echoes within anechoic structures when scanning the portal vein. A systemic approach must be used to evaluate and document the entire liver in both the longitudinal and transverse planes, using specific anatomical landmarks. Colour Doppler imaging is to be used, using a 60-degree angle or less to evaluate intrahepatic branches of the portal vein. And hepatic veins should also be examined to assess the extent of the thrombus. If any abnormality is found, it must be measured and documented in 2 scanning planes, with and without colour Doppler. Differential considerations for portal vein thrombosis include Budd-Chiari syndrome, cirrhosis, or technical error. To avoid technical error, the examiner should review the scanner setup and reevaluate scale, gain, and filtration appropriately. If there is still no perceptible flow, the patient should perform the Valsalva manoeuvre. This manoeuvre elevates the intrathoracic and right atrial pressure, therefore transmitting higher pressure to the IVC, hepatic veins, and subsequently into the liver parenchyma. This increased pressure causes even greater resistance to the portal venous inflow and may convert stagnant portal flow to hepatofugal flow, thereby decreasing the risk of misdiagnosis. Intravenous ultrasound contrast can be used to lower the risk of misdiagnosis as it can detect very slow flow.
In conclusion, ultrasound is the preferred imaging modality for PVT as it is non-invasive and reproducible. Therefore, as third-year sonography students, it is important that we have a thorough understanding of this condition. Please don't hesitate to ask us if you have any further questions in regard to portal vein thrombosis. Thank you.